Good day, ladies and gentlemen, and thank you for joining the SPS Medicine's Reducing Medicine's Harm Across Transitions conference call. My name is Maija, and I will be your moderator for today. If at any time you need assistance, please press *0, and I will be happy to assist you. I will now turn the call over to Clinical Lead for SPSP Medicine.
Hello, thank you very much for that. Welcome everyone. My name is Arvind Viraya. I'm the medical lead for the SPSP Medicines team, and welcome to the 6th WebEx in this monthly series for 2016 on reducing medicine's harm across transitions. The aim of this WebEx is to support learning and sharing between boards regarding reducing medicine's harm across transitions, because we know that that contributes to a lot of harm across the whole system. Today's presentation will be by NHS Borders, but before we start the presentation, I'd like to remind you all about a few things about the WebEx itself. Can I make sure that everybody's got their phone on mute? Their mobile phones, etc., but also your phones, which you're calling in on, are automatically on mute. But we do want to hear from all of you. We want to hear comments, and we want to hear questions from the audience, which hopefully NHS Borders will be able to answer, but we can all discuss this. And for that, we'd like you to use the chat box, and that's usually quite well used during these WebExes. Please type in your questions as you think about them, and then later the team here will be constantly looking at the chat box to pick up questions which we'll put to NHS Borders, and they can look it up in their own time as well. Just a quick, we're having a little bit of difficulty moving to the next slide, but just to quickly tell those of you who are not used to this, on your screens, on the right-hand side panel, you have a picture for a chat, and if you click on that, at the bottom of that page, you'll find a drop-down menu, and can you please choose all participants when you want to put a question to everybody. We'll be looking at it in the panel as well, and be noting the questions down to put to NHS Borders. If you want to send a private message to anybody, you just have to click on that drop-down menu as well, and then you can choose to send private questions, but make sure that you revert back to all participants in order to make the discussion as good as it's possible. Can I also ask all of you to actually introduce yourself in the chat box before you start with your questions? It'll be really helpful to know who you are and where you work, so that those replying can give you the right answers. So the last 3 WebExes, just to remind ourselves, we had in May NHS 5 presented, and in June NHS Grampian, and in July we had NHS Forth Valley present in the last 3 WebExes. These have been very useful for the SPSP Medicines team, and hopefully have been just as useful for all the participants. We've certainly had very positive feedback from boards about this WebEx. Our learning from these WebExes, and in other work as well, but the main 3 key points that we picked up were that medicines reconciliation is a complex clinical process. Every time we come across the discussions in the WebExes, it's absolutely clear that senior medical engagement is key to success in acute care particularly. And it looks like every board is actually looking to get better information about how well information is transmitted across transitions. Our last WebEx was from NHS Forth Valley, and their 3 key points are on your screen. They presented the work of their community pharmacists, which is really helpful, and all of the people in the audience took away really useful messages from it. We also got the message was reiterated that it's really important to get engagement and support from leaders, particularly medical and nursing leaders. Pharmacy leaders are always involved, and they're always very helpful in this work. We also got an experience from listening to their presentation about the challenges with implementing HEPMA, and this is something that other boards who haven't done so might learn from. These WebExes are available for people to look at on the website as well, and you can pick up later. So that's the introduction done, and may I welcome now the NHS Borders team. The program manager for NHS Borders is Julia Scott, and Julia will introduce the rest of the Borders team who are presenting. Over to you, Julia.
Hi, Arvind. Thanks very much indeed. Hi, everybody else. I'm not reading any presenting today, but I'm delighted to say they've got Catherine and Lisa, who you can see in the screen, who are in the room here, who are doing the presentation today. Just also to say we have Dr. Andrew Murray, who's our medical director. He's here as well. He's helping us solve the whole MedRec problem. So I'm going to hand over to Catherine and speak to you later. Bye.
Thanks, Julia. Good afternoon, everybody. So our presentation today is looking at medicines reconciliation across NHS borders. I'll be discussing around what we've been doing on the medical admissions unit, and then Lisa will give some input around the nurse-led medicines reconciliation process in our mental health unit at Huntley Burn Ward. And then at the end, I'll just summarise a bit of work that's been done in primary care as well around medicines reconciliation. So to start off with medicines reconciliation on MAU, a bit of background to what's been happening at BGH. There's been a lot of input kind of over the years to a variety of clinical areas, including the admissions unit, surgical, orthopaedics, ITU, and paediatrics. But as of this year, we've kind of had quite a drive and quite a focus on the medical admissions unit, because there's been a number of changes that have taken place since December last year, where we've incorporated a new acute assessment unit which takes GP referrals, has patients reattending for review, etc., etc. So that now incorporates into the admissions unit. We have junior medical staff who rotate in to cover the unit from their medical rotations. And I guess a bit about the demographics of the patients we see. They can sometimes be quite complex patients with regards to medicines reconciliation, because I guess given the nature of the hospital, we do see some complicated patients such as oncology, haematology, or dialysis patients, etc., etc. But we also have quite an elderly demographic. So as you know, given the nature of the age of the patients we see, they can be on quite a lot of medicines with a lot of input from different carers associated with that. So it's a lot of information to pull together. So as I've mentioned, we reconvened the Medicines Reconciliation Group in January of this year. We've initially met weekly, and we've had good engagement from the lead clinicians. So we've got lead consultant for MAU, Dr. Lynn McCallum. We've got on board an acute physician, Dr. Chris Evans, our medical director, Dr. Andrew Murray, associate director of nursing, Charlie Sinclair, as well as the patient safety team, and various pharmacists who cover the admissions unit. So we started our data collection in March this year, and this was collected by the ward pharmacists who were covering the unit, and the results have been cascaded at a daily huddle on MAU each morning. We appreciate that kind of across the board the requirement is probably 20 patients per month. We've done quite a concentrated data collection with 5 patients per day, Monday to Friday, which is when the pharmacy team cover the unit. So I'm just going to have a quick sort of chat through our run chart of our data collection to date. It's quite a busy run chart, as you can see, but hopefully it demonstrates the kind of involvement we've had from senior staff to junior staff, and that's been a true multidisciplinary approach with grand rounds, ward safety huddles, hospital safety huddles, the message just sort of getting out there across the hospital. As you can see on the run chart, we have demonstrated a shift whereby we're demonstrating improvement with our medicines reconciliation, which is circled in red, as we had a number of points kind of concurrently above the median. So that's where we're up to today. And there's been, I think it's fair to say, kind of around July time, we probably had a bit of a hiatus kind of with the tested change we were doing, because we decided to kind of have a bit of more of a drive towards new doctors starting in August. So I just thought I'd break down the bundle for MedRec to demonstrate where perhaps some of our weaknesses and strengths are around medicines reconciliation. We've been relatively consistent with documenting allergy status, and I think it's like, to be fair to say, we've shown improvement with that over the month. Our demographic documentation has been somewhat variable, and it's something we've again tried to have a big drive on. I think we quite often get we have a performer on the medical admissions unit, so we quite often have the patient details on the front page, but it's ensuring that the demographics are also on the medicines reconciliation part of that performer. Again, two or more sources has been one of our other challenges, but I think we've sort of demonstrating from the beginning of the data collection to now, it has been variable, but we are sort of getting the message across with regards to the importance of this being documented in the notes. And again, with documenting our medicines plan to whether to stop, withhold, or continue medicines, we're just sort of reiterating the message on a daily message to all medical staff, and trying to seek improvement there. This is a copy of our medicines reconciliation page that's in our admissions performer, and it's just demonstrating what we expect staff to kind of comply with each patient that is admitted, and this has been sort of cascaded across the hospital and reiterated on the wards each day. On the basis of using ECS a bit more widely, as it is quite often used as one source of medicines reconciliation, we took a decision to sort of start using the ECS reports where it is applicable to patients. Some patients we see are out with the area, but the vast majority of our patients do have ECS records, so the decision was made, yes, the performer can be filled in, but as an alternative, the ECS report can be printed off, because by doing that, a number of the components of the bundle are automatically populated, so to speak. We should get demographics from that. Usually we get allergy status, and we actually have the list of drugs, as I say, as one source of information. So what the doctors, therefore, and pharmacists and other staff involved, therefore, need to add in the second source of use and their medication action plan. So again, our progress to date, we have been showing improvement over the few months, working towards it, as I previously mentioned, on our weaker spots. But we've done daily huddles, we've displayed posters on the ward, we've had medical director attend junior doctors meetings, we've had grand round presentations, we attend hospital safety briefs, and we've also had a lot of input with the FY1 induction programme in August this year. I'd just like, as part of our successes, to acknowledge the pharmacists who've been working on the admissions unit. I think they've really done well to kind of get really good engagement with the medical staff and the medical director, as well as the nursing staff and the lead consultant there. I think they've done really well in that respect, and I'd like to kind of acknowledge their work, although they're not presenting today. From the draft OPAT inspection, we received some positive feedback regarding the pharmacist input to the process of medicines reconciliation, and I know this has been a question asked previously on the WebExes about at what point is the data collected, sort of before or after pharmacy intervention. We've also had quite a lot of success with upskilling our pharmacy technicians, so they've now got greater involvement on the ward regarding admission and discharge and engagement with patients with regards to discussing how they manage their medicines. Some of the challenges we've faced with this process are we have, unfortunately, running with quite a high number of locums, which makes the sustainability of teaching, training and education a bit difficult to sustain. Likewise, with the number of consultants covering our unit, it's getting that kind of across the board not been easy, but we are seeking improvement, like I say. We also have a slight challenge with real-time feedback to the doctors and hospital at night team who are doing the medicines reconciliation from a pharmacy point of view, in the sense that we're not there at the time that this is happening. And we've also perhaps been slightly limited with our clinical pharmacy capacity as well. We've also been implementing different new ways within the pharmacy at the same time as kind of seeking this improvement. So there's been a number of challenges to kind of meet various different work aspects. Our future plans for the MAU, we've had a slight change in the way in which we collect our data collection to make it a bit more multidisciplinary, not so pharmacy focused. So we're now collecting it 3 times a week, still 5 patients. We've got broader kind of involvement from the medical staff and safety team, as well as pharmacy collecting the data. We've also had at BGH recruitment of CDFs, which we are hopeful will reduce the number of locums we have here, which again would help with sustaining education and training around medicines reconciliation. There's ongoing work with remodelling of medical services at the BGH, so we will obviously sort of see how pharmacy and pharmacist work align with that. And quite importantly, I think we are now starting to align MedRec with the local ADTC to look at improving medication safety as a whole. Alongside this, we also have a VTE improvement advisor who's been recruited through HIS funding, and whilst VTE isn't necessarily medicines reconciliation, again it raises the profile of medication safety overall. We're also looking to introduce name stamps for all staff who make entries into the medical notes to make it easier to identify who we need to feed back to about medicines reconciliation if there are discrepancies. So I'd just like to give some acknowledgements and thanks to members of staff that have been involved with this behind the scenes. Joyce Bowden has been crucial to our data collection, and like I say, our ward pharmacists, Lois Gold and Sean McPherson, had a great deal of input working at ground level with the medical staff, and Catherine Scott as our lead pharmacist. And I will just hand over to Lisa now, who will discuss nurse-led medicines reconciliation.
Thank you, Catherine. I'm going to talk about what we do at Huntly Burn House through nurse-led medicines reconciliation. We've been involved with the Scottish Patient Safety Programme for about 5 years now, and we took on the work stream of medicines reconciliation, and we've attended all the study days over the past 5 years and looked at all our data. Our data has always been quite good, and we got a visit from David Maxwell about 3 months ago now, just to go over the process that we had at Huntly Burn. And I think we kind of see it as quite unique, because we're not sure of many other units that use the nurse-led process. So when we started it off, when we looked at medicines reconciliation, we looked at the process of it and who was involved throughout that whole process. And that became clear to us that it was nurses who were admitting the patient along with the medical staff. So that's the process that we follow. We're a 19-bedded acute mental health ward, and when the patients are admitted, the nurses take ownership of that process and ensure really that the medical staff have completed the parts of the form that they're supposed to, and assist with getting the emergency care summary and the medicines ready for the doctor coming in to admit the patient. We do our action coding on admission, and then again at the first review with the consultant. When David Maxwell was down visiting, he wasn't aware of many other areas that had this process, and I think we felt that it was maybe one of our successes in Borders was to have the nurse-led process. I do have to say that we have a lot of support from medical and nursing leaders within the organisation, and I should really give a mention to Dr. Cliff Sharp, our medical director in mental health, because we pass all our data on to him every month, and he does chase up anything that has been an issue. I'll show you the data. So yeah, we do aim for 95%, and often we do sit under that. Some of the changes that we have noticed is if there's new junior doctors, our data takes a bit of a dip. It is included in their induction now, but it's the nursing staff that induct them to it, so they're used to the process that we use. And again, we changed our paperwork recently to a unitary record, and that has caused a dip recently. So that's about it really for Huntly Burn. So I'll pass you back over to Catherine. Thank you.
Thank you. I'm just going to present a bit of information about a project that's happening in primary care at NHS Borders as well, on behalf of Keith McClure, who's the lead pharmacist for medicines utilisation and planning, and he's more than happy to be contacted if anybody has questions about the project. So it's a primary care medicines reconciliation project carried out in One Borders GP practice with average demographics for the area. It was conducted by an experienced primary care pharmacist who also had previous hospital experience, so they were able to kind of appreciate the systems from both sides. They visited the GP practice twice weekly for a month from January to February, and they reviewed 33 discharge letters. The average age of the patient was 60 years, and the average number of medicines on the letter was 10. They reviewed the number of medicines that were added or removed from the repeat system at the GP practice, and they also reviewed the number of dose changes that were happening, approximately 1 in 5 letters that was happening for. They also looked at the number of drugs that were actually admitted, so i.e. medicines that the patient was on before they went into hospital and where they weren't documented as being on a discharge, but there wasn't particularly a reference to why it was missing. So overall, 70% of letters basically had a query of them, and the average time to look at this and resolve it was 18 minutes, but the shortest amount of time was about 3 minutes, and the longest was 70 minutes. So just highlighting a few of the kind of major findings that I guess came out of the project was, and I guess it demonstrates some of the challenges that we have in this area, is that a number of patients are likely to be under sort of joint care between ourselves and Edinburgh Hospital. So there was a letter from ourselves at Borders General Hospital, but the discharge had actually been from the RIE, and there was 5 medicines missing from the discharge with no explanation if they were missing or intentionally stopped, and it took over an hour for the pharmacist to get to the bottom of that and sort of get answers to that. Another one that took quite a number of time to sort out was 5 medicines not on discharge, and again not documented if stopped. And then the final kind of highlight from the project was 3 calls to RIE and waiting for calls back around a number of medication changes, and it took about an hour to sort out in the end. So what the practice-based pharmacists are starting to look at in the area is promoting general good housekeeping from the GP prescribing system, so removing duplicates, obsolete, amongst other things. The other issue that they've identified is that from the prescribing systems, no drug will show until it's actually been issued. So there's a bit of discrepancy perhaps between what is on ECS as opposed to what has actually been prescribed, as well as alongside any acute and sort of, I guess, out of hours, so on and so forth prescriptions, which is probably across the board. And as well as that, they're trying to look at ways in which we can use ECS a bit more robustly to think about medicines that are perhaps prescribed in the hospital setting, but it's sort of pertinent that there is a record on it for all to see on the ECS system, so perhaps medicines from psychiatry, etc., etc. So as I say, Keith is more than happy to be contacted if any more information is required about that. So just to summarise, we've been asked to sort of give some key points for sharing. So we're more than happy for if anybody wants to ask us about nurse-led medicines reconciliation, ask us about senior clinical engagement and our primary care project. Some questions we have for the other boards and anybody listening out there is, for anybody with electronic prescribing, has that provided an aid to the process of medicines reconciliation? And our second question is, at your board, who owns medicines reconciliation? Because I think we've demonstrated here we've got quite a multidisciplinary approach to it, so I'd be interested to know sort of how it works well in other areas, if you're working anywhere differently. And another question we sort of have regards to our acute patients coming through the medical or kind of acute surgical units, is if patients are acutely unwell with regards to the bundle and unable to discuss their medicines, how does this affect your results and your data collection? Thank you very much.
Thank you very much, Catherine. That was very quick and excellent presentation from all of you. Now, I'm a little surprised that there have been no comments or questions in the chat box. Can I just check how many people? Can people just introduce themselves in the chat box? I'm unsure whether people have actually got access. Usually there are some comments. So while I'm waiting for people to add some comments or questions, my colleagues might check whether the others have got access. Can I ask you a question? We had heard about the work in Huntley Burn and about nurse-led medicines reconciliation. In the medical admissions unit, though, a lot of the work seems to rely upon the junior doctors. Have I got that right? And what are the challenges with enhancing the work of nurses in medicines reconciliation at the MAU at PGH? Are there challenges?
Want to comment on that, Lisa, or from a nursing point of view?
I know. Obviously, I'm just talking about Huntley Burn ward, and we're 19 beds, and we'll have less acute illnesses coming in to the ward with complex medicines history. So I think that's maybe one of the reasons why it's easier for us and more difficult for MAU, who are having numerous admissions throughout the day with complex needs. Do you agree?
I think so, yes, and it's certainly something we're kind of looking forward look to in the future, kind of whether there's any capacity of the nursing staff to support with this on MAU, and we kind of acknowledge our kind of efforts have been towards the medical staff at the moment, and we'll sort of take that forward with the nursing staff to see if we can get any support with the process. Yeah.
Does anyone else use the nursing staff in acute areas?
So does anybody else in the audience have something to add about using the medical staff in acute areas? So it's a pity our nursing lead, Linda Patterson, isn't in today, but she certainly was involved with medicines reconciliation, and in their own hospital there are instances of there is much more support for nurses to be involved. But I think for most boards, it's still a process that relies heavily upon pharmacists, unfortunately, and on junior doctors. And even going by the data that were presented today, we always come back to the same problem. You have new junior doctors, new FY1s, medicines reconciliation drops sharply because you're constantly training a new group of people. So within SPSP Medicines, one of our priorities is definitely to try and involve the entire multidisciplinary team. And Huntley Burn was a fantastic example for us of how nurses could take ownership. I'm really keen, and our team is really keen to hear more examples like this. And in my workplace, I've tried to get it moving. And there have been some challenges, but it would be nice to know what challenges other people have faced, or whether they've actually tried to get nurses engaged. Okay, while we're thinking about that, Pamela Mills has written on the chat that HEPMAT definitely improved the medicines reconciliation process at discharge particularly, and using the ECS medicines reconciliation template has streamlined it. I think the use of ECS and the use of ECS template is certainly the way most of us are moving, using as much of an electronic solution as possible. Now, from your presentation, Catherine, it seemed like for some of your patients you could not use ECS. Is that right? Did I get that right?
Yeah, just because some of our patients come from, it's not huge numbers, but some of our patients come from over the border in Berwick, and yeah, so some of our patients come from the England side, so we don't have access to their medicines through ECS.
Right, so that's a challenge. Yeah, while we're waiting for a question to be, can I just say, for those of you who are on the Q&A screen, can you, on the right-hand side, on the top, if you click on the chat button, and then at the bottom choose all participants and send it, it will now become visible to everybody. The Q&A screen isn't working well this time. So there's a question that we forwarded from Murray Patterson about whether there are any plans to roll out the pharmacist role in carrying out MedRecs to other practices. This is the primary care medicines reconciliation. So before we go to anything else, Catherine, any answer to that?
Well, just to sort of say that basically kind of at Borders we've kind of recruited a number of practice-based pharmacists at the moment, so it's not the area I cover. Like I say, it's kind of Keith's area, but I guess they're sort of reviewing the role in there at the moment and just sort of seeing if this should be, you know, how much pharmacist involvement they should have. But like I say, Keith is more than happy to be contacted about the work that we're doing in primary care here.
Okay. So going back to engaging to the medical admissions unit and data on medicines reconciliation of the medical admissions unit, one thing that struck me is how often my employer seems to be guilty in the problems in NHS Borders, because two of the cases related to the Royal Infirmary of Edinburgh. But it did make me think that when we are talking about transitions, we had originally thought about transitions within the board. I guess what you spoke about, Catherine, just now is from England to NHS Borders, but also from other boards, so transfers within boards. And I'm not sure whether this is something we really looked at all. Is this a problem, Alistair, or anybody else in the audience have seen particularly patients coming from other boards, particularly being a challenge for medicines reconciliation? Oh, we have time. Okay. Right. While people are still thinking up of any more questions or comments to add out here, can I just move on the slides, and we'll come back to any further questions or comments. But while we're thinking about this, I'd also like to ask all of you to give us an opinion about how much, whether or not these WebExes are helping, and what we can do to make them better. So we will be sending you out an email later on today with a link to an online evaluation form. This will be really helpful for us to plan the future WebExes. So I'd be grateful if all of you could fill that out and send it to us. And in future WebExes, we will be continuing to evaluate the WebExes themselves. Going back to your presentation, as nobody else has come up with any particular question. Oh, Alistair. sorry, I'm just reading the, can you pull up Alistair's email, Alistair's comment?
Was that a private comment?
No, he's, sorry about this. I feel the lack of David Maxwell out here. He's, Alistair has asked, has made a comment. In NHS GGNC, we had a mixed experience using an e-form for MR on admission. This pulled medicines from ECS but did not link to IDL, and we're now developing an application in our clinical portal which will link the medicines list created on admission to the IDL, further reducing transcription and offering a greater incentive to completing the MR process on admission. So I guess this is Alistair talking. This is an example of how IT resources can be used to the best possible, in the best possible way, even in boards that are not fully dependent on HEPMA to deliver all their medicines reconciliation. Catherine, I'm curious about in the run chart. One of the things that stood out for me was that among the many things, many interventions and points that were described out there, there was one about Dr. M going on holiday that made a big difference to your data. Is that right? How did that happen?
I think we're just sort of acknowledging that when Dr. McCallum, it's not so much that, you know, kind of all parts mentioned today, but she is the lead for MAU, and so I guess when, you know, her presence kind of means that there's a kind of consistent message getting across about medicines reconciliation at the daily huddles and on the ward rounds, etc. So it was just, I guess, a bit of a reference that, you know, to get across on a daily and weekly basis. So.
Yeah, I work with Dr. McCallum. I can fully understand that. But it does come back to that issue that you really need medical nursing leadership as well to actually ensure that people participate fully in medicines reconciliation. But it is a real challenge. If you have one champion, they can't be there all the time and they go away, it fails. I was clearly your team have put in a lot of effort. It's part of the induction. You've had the medical director participate and talk to people about the issue. What else? How else can we prevent this drop-off when new doctors come in? Is there any other thing that you think might help?
Hi there, this is Andrew Murray. I'll just come in on that point. I mean, I think it is extremely challenging. When you look at our run charts, we actually achieved 100% in a few weeks for all components of the bundle for a few of the weeks in May especially. So the difficulty for me is if it continually sits with the junior medical staff, I'm not sure, and I'm interested in other boards' experience, whether or not 100% is achievable or realistic because of that variability and because of the way the job is done. I'm a great believer in giving one person one role, so that person has the clear role for MedRec. Now you might say it's all junior doctors, but I think it's too easy for distractions and prioritisation with sick people coming in for that not to happen. So that's why when I hear the Huntly-Burn results, for me that's a kind of more obvious way to go, with permanent members of staff having it as part of their routine and not having to go through that training process and having clear roles and responsibilities around it. So I'm not sure it is solvable with junior doctors, especially in places like MAU, and that's why I'm keen to see how far we can go with it, and having, as you hinted at, a strong consultant making sure that this message gets across clearly is very important and provides some focus. But all it takes literally is for that focus to step back. A new batch of doctors will go to MAU almost on a daily basis, and we're having to repeat the messages. For me, that's, you know, there's only so far we can go with that. And for me, having somebody in MAU and it's their job to do MedRec, no matter what level they are at or what discipline they're from, the total clarity about that, and that's basically maybe the main component of their job, that would be another way to try and deal with it. And it's the way that other difficult problems tend to get progressed. But it's easier said than done. And at the moment, I think we will try and continue to exhaust all possibilities. Because for a while, we were actually doing really well, and I would draw your attention to that, to those 100% on the run chart, which subsequently tailed off. So we're continuing just to try and maintain that, but I think you're really picking up, for me, the key challenge, and that's sort of my thoughts as to how we get around it.
Thank you very much. I think it's clear from the run chart, I should have said before, that you've shifted the mean anyway. There's a substantial shift in the in medicines reconciliation, and yes, achieving 100% and really high values. I think some of our medical admission units, certainly my own, would struggle to achieve the values that you have. That's what we are finding as well, and I'm sure it's a common thing that working with junior doctors, it works as long as there's a champion, and then it's really difficult to sustain it. So thank you very much for giving us your insight in that. One question about using permanent staff, whoever they may be, is of course the doctors always see every patient, as do all the nurses. My own border challenge has been that in the daytime we can get nurses sometimes to support this activity, but they are always worried about bank nurses on night shift, and again, they too have a challenge in ensuring continuity for this process. One of the reasons we couldn't move as far as we wanted to with supporting or engaging nurses in medicines reconciliation in our MAU. Okay, if there are not, I'm just looking at the chat screen as I'm talking, which is bad for me. I can only do one thing at a time usually. And I'm looking at Murad's comment. Okay, if there are no more comments or questions, please feel free to add them just now, and please email us or let us know, and we can always email the presenters to ask for further questions. This presentation will be up on our website for people to look at on Tuesday, so not yet. So from Tuesday, you can all have a look, and you can ask your colleagues to have a look. And if you have any further questions, please let us know, and we'll forward them to the presenters. That's on your screens now, the dates for the next presentations. So on the 15th of September, we've got a presentation from NHS Lanarkshire, 20th of October from the Island Boards, and 17th of November by NHS Highland. And it'll be on the third Thursday of each month for those of you who just have to set it up in your calendar, and that'll be really helpful. If there are no comments or questions, then I'm going to close now. If you want to contact us, our contact details are on the screen. Please feel free to email us or call us. Thank you very much.
Thank you. Thank you.